So I'm going to give you a short summary of a patient who will be treated later within this session, most likely, you will see. This is a female patient, 74 years old, obese, who presented with us to us with clear signs of dyspnea on exertion. Her heart failure symptoms actually worsened recently. She's also known to have permanent AFib, arterial hypertension. She has some coronary atherosclerosis, but no relevant stenosis, impairment in kidney function, stage 3B. These are the most relevant comorbidities. Her current medication is summarized here, and you see that it includes already a couple of diuretics. So that's probably the most important slide. You see the echocardiogram of that patient. Left ventricular function is well preserved. Nothing too exciting in the four-chamber view, but then on the right you see X-plane view, and you can also see on the long axis on the right the pathology. So obviously here something is not quite right, and you can also see that this refers to more the medial aspect of the mitral valve. This is a 3D image, obviously. You can see that a severe mitral regurgitation, and this is due to a medial commissural pathology. And I phrased it quite vague because it could be interpreted in different ways, but it's commissural, and there is a pathology. She underwent coronary angiogram, no relevant stenosis, also right heart catheterization, demonstrating pulmonary hypertension with obviously increased wedge pressures and a predominant V wave indicating significant mitral regurgitation. So a typical finding in postcapillary pulmonary hypertension due to severe MR. That summarizes her other lab results. When you look at the risk scores, you might not think that the scores are that high, but that's probably one of the typical patients where the scores do not necessarily reflect the frailty. She was on assessment, and this was a heart team assessment, clearly considered to be frail, and this is why the decision was to proceed with transcatheter therapy, and in this case using the PASCAL device. Thank you.
Thank you, Philip. It's an interesting case. We will be waiting to see how you treated it. But in the meantime, I want to see with the panel. Would you also have went directly to a transcatheter, Jörg?
Well, I was joining the procedure, so of course I would have done the same.
Conflict of interest. Let's switch to somebody else. Wolfgang.
Yeah, I think it's a quite unusual anatomy, and I didn't understand the etiology of the mitral regurg so far. Could you give us some more hints?
Wolfgang, so I thought the same. When I went to Leipzig, I thought, oh God, this will never going to be a good case.
Okay.
I could share more details with you, but first we will see more details during the case, and then secondly we had to make a decision with the information I presented to you, so it was also not for us any clearer. Then you could argue whether you should bring the patient back, do another TEE, bring everyone in the same room, or use the image we had. And I do agree we had some discussions about what's the exact pathology, but obviously it was degenerative, it was commissural, it was medial, the risk was high for surgery, and this is why we were relatively optimistic, or at least we thought it's a good idea to try to treat it by with a PASCAL implantation.
Okay. Thank you. We are back now to Philip, and now it's time to find out how the case went and what was the strategy in this case.
Hello and a very warm welcome to Heart Center Leipzig for PASCAL implantation to treat a patient with degenerative mitral regurgitation. I have with me today, and as always, my dear friend and surgical colleague Thilo Noack. And then we also have the honor and privilege today to be supported by Jörg Hausleiter from Munich, one of the legends in the field. And I dare to say that what we are faced with today is quite challenging. So It's a perfect day to have you on board and to support us with your experience. Without further ado, I'm gonna hand over to another very important person for the procedure, which is Professor Ender. He will guide us through the procedure by performing the TEE, and we're gonna jump right into the anatomical and morphological details of that case. Please, Mr. Ender.
Yes, so thank you and a warm welcome also from my side. You see there's some flail here. You see that with that ruptured cord? And we can discuss that if it's a P3 flail or whatever. And if we go to the 3D, see that here we have the anterior mitral leaflet, the posterior mitral leaflet, and this is the flail part. So it's hard to differentiate if it's a P3, if it's an A3. In my mind, it's more a commissural additional leaflet.
And what you can also appreciate here are the gaps we are supposed to bridge, obviously. You see the massive MR.
Yeah, effective regurgitation orifice area of 0.9, which is really huge. We have no systolic reversal due to the eccentric origin of the jet. And you see in the commissural leaflet, you see that very nicely, that we don't see here a coaptation point. So we have to adjust the angle in X-plane, and now you see here that flail leaflet with that ruptured cord on the left side.
Yeah, comments. Any comments from the panel?
Still the same, tough case?
But the good thing is that you have tissue. I think they are the cases that you don't have tissues, they are the worst cases. I mean, I think this is a matter of being precise and grasping the tissue that it has to be inside. And probably the thing is that all this imaging that has been difficult to define to the echo guy has to be inside the device. So you have to not restructure the mitral, avoid all this tissue. Maybe you need 1 or 2 devices, we don't know, but at least you have somewhere to go.
Yeah, we thought so too. I mean, we weren't entirely sure whether it's an additional leaflet or whether it's P3 or A3, but obviously it's a commissural pathology. It is a massive MR, and as you said, there is some tissue which can be bridged, and that was the treatment goal. I continue.
Hello and a very...
So Philip, why are you using the A's, or why did you choose the A's over the classic?
Yes, so
PASCAL device?
Obviously the difference is the width of it. 10 is compared to 6 millimeter, but the other difference is also that with the ACE device, the spacer is a bit smaller, and I believe that has a certain implication that the 2 petals, they come closer together. So in other words, I believe that the grasping force is higher with the PASCAL ACE, and in a very dynamic environment like this one, I really would like the leaflets to come together as closely and as firm as possible, but at the same time obviously preserving the leaflet and not causing any harm or injury. Okay, so I think for this case and for most, we should make the most of the opportunity to measure simultaneously pressures.
Do you do this on a regular basis, or?
Yes, I really find it helpful. By the way, it's also one of the strongest predictive measures in these procedures of all, the reduction in left atrial pressures. And especially in that case, we have high LA pressures, we have a very significant V wave, and I very much hope and expect, if we do it right, this pressure to come down during the first grasp.
Yeah, I do this as well. I always have a left atrial pressure monitoring, because it tells you right away if you have a good leaflet capture when you close the system, and if you have reduced the MR effectively, even faster than any echo assessment.
There we are. So what do we think about the travel, the path of the device? What we see also here nicely is the power of the MR and how the device is pushed away once we are at the center, the epicenter of the regurgitant jet. But that's to be expected. I think it's not bad. I think that's good. let's open it and check the clasp, because we certainly will use independent leaflet grasping here.
How often are you doing an independent grasping as the first grasp with this device?
Yeah. So we go for simultaneous grasping unless unless it's really needed to independent. But what we almost always do and use is the so-called single leaflet optimization maneuver, meaning that the first grasp is simultaneously, but then we optimize the one or the other leaflet by do it then independently.
I must say, I changed my way of working a little bit. I'm very, very open for individual grasping, also for the first grasp and swing over. This technique really allows you to have an optimal visualization of the one arm and the one clasp with the leaflet, and then you can swing over to the other one and focus on that one.
Yeah, I totally agree. Okay, we cross the valve. We will double check on fluoro whether we've changed our clocking, maybe a little bit, but that we will see better once we open the device. Let's go to the X-plane view again. We're still in the breath hold. You see, we do have some time, but not endless. Can we see color here, please?
The V-wave, I think, is very interesting. It's almost gone. Huh?
That's why I wanted to see color. So I think the pressure tracing there are reliable. Okay, can we have on the view, can we add pressures as well, please?
Wonderful. Yeah, I think this is very impressive. If you see the PASCAL is not closed, it's still in its open position, but the V-wave is almost completely gone.
Well, let's try that. Okay, let's bring them. Now we can do simultaneously because obviously,
they're very nicely on.
Yeah. So we bring down the clasps and we close the device and move in a little bit. Device is closed. All right. Breathing on, and then we discuss everything. Yeah.
I think when the device was closed, one could really nicely see the tensioning on the night. You know how the PASCAL was opening slightly, and here one can see this again. How gentle it is. MR is gone. There's at least a little bit of prolapse tissue still.
Yeah.
Medially, right?
In the medial part.
Yeah. Can we cursor even more medial, please?
Yes. For this, I have to make the color even smaller.
There's no PISA.
Tiny bit. There we see we have a bit of there.
There's a little bit.
Prolapse, but there's no PISA below the leaflets. The hemodynamic effects tell you that you have a perfect result.
Yeah, from a morphology, anatomy point of view, would think that we add another one to stabilize it, but then you would like to have this one to be even more medial. I totally agree.
Of course, we have the mitral valve orifice is large enough, so we can still place a second one without having a significant gradient.
Okay. May I suggest the following? We do another breath hold. We open the device. We will not lose position. And then we can bring up the clasp very gently and then try to be a little bit more medial.
What is your rationale to do this? Just to explain it to the audience.
So it's all perfect now, but I think we also have to respect the anatomy and what we are seeing. So we see still some prolapse left medially, and I think it will be more stable if we go medially and then place another one next to it laterally. You agree?
There's no pathology lateral to it. So
bit of MR though.
Yeah.
Okay, then we open the device.
Okay, go for it.
It's just, at that point, did you thought about the clocking of the device?
Yeah, that's part of the opening of the device, right? Because once it's closed, sometimes it's more difficult to appreciate whether the clocking is perfect or whether the clocking stayed exactly the same. That's why the idea was to open it up, maybe correct the clocking, but also move in a little bit more medially. Because although we did not have a lot of residual MR, we could see that there is still prolapsing or flail tissue. And that was the rationale behind it.
So if we turn a little bit more counterclock, we are respecting more the line of coaptation. and we're more perpendicular to the line of coaptation in this very medial commercial part of the mitral valve.
Okay. Now we can appreciate that the clocking is much more 12/6 o'clock than we wanted it to be. So, yes. And again, it makes the point, some things you can appreciate better once you open the device. Pressures go up now again. That's to be expected. Yeah. We will do the clocking in a second, but I'd also like to come more medial. Okay, let's bring up the clasps. Okay, so I'll try to be more medial now. 3D, please. We change the clocking. That will change the medial lateral position as well.
And maybe we can even come a little bit more medial, huh?
Yes, and then more medial if possible, but that's not easy. There is already a bit of tension on it. Okay, explain again, please. Okay, so if we leave the leaflets on, then that's what we can achieve. If we want to be more medial, then we would have to lose the position here. But it's possible, obviously.
Shouldn't we give it a try?
Yeah, well, we have abandoned leaflet tissue on. Let's do anterior first, please. Posterior. Posterior is down. Then we close the device. Okay, so what's important now? To make sure that we don't have MR left medially. This is the clocking is better now?
Yeah, clocking is better, and I think if you can have the color Doppler flow on this 3D, we can nicely appreciate the jets, okay. There's still two tiny jets.
It might be more laterally now because we went more medially, but that's fine because I'd like to place another one there anyway.
I just cut down the plane just to be sure where the color flow is coming from, and it seems that it's really all laterally.
Device looks very stable, and there's no change in the V wave and no change in the Doppler color flow.
Yeah. So you said the device looks very stable. I agree. For the pathology we treated, if you see something like that in functional, then you're slightly worried. But in degenerative, that's to be expected, and it sort of supports our decision to go for second, right? What's the degree of MR now after release? Maybe we should discuss that. I mean, treatment goal, because we all agreed it should be mild or less in these patients. It's moderate. Moderate is not
acceptable anymore.
It's not acceptable anymore.
I would say it's moderate because we also I've recorded that. You see still a little bit the systolic wave in the pulmonary vein lower than the diastolic, and it's on the right as well as on the left.
Okay, you can hear that our echocardiographer is quite strict, but that's good because that gives us better results. He was also not very encouraging to start with and said that it's not a very good idea to select such a case for life in the box, but we tried anyway. As you could see, we crossed the valve with the device being closed. We normally would not do that for mitral procedures, but because we had to go very commissural, that in that case we actually did it. And you could also see that although we had a sort of acceptable or even good result with the first grasp, we thought that it's important not only to look for color, but also for the anatomy and see whether there is still prolapsing or flail tissue left, and that's why we moved more medially.
Okay, orientation is fine, but not close enough, not close enough.
The question is if the cords will keep us away from the first device now so that you have the difficulties to swing close enough over to the first device.
Okay, anterior is a lot of tissue in. Let's bring anterior down, please. And then double check on 3D for the clocking. Okay, anterior is down. We even came above the posterior now, but that's fine. We fix it in a second. Clocking
anterior, you're very close to the first device.
So clocking is fine, right?
Yeah.
Or do you want?
No, I think it's good. Huh?
Yeah, Kilo. All right. Explain. So here you see that posterior we are above. I go in now gently because we are in proximity to the first, and We have one already down. Now you see the device rolling. So either we wait until it sorts itself, which it did.
I think now it's not rolling anymore. It's curling because it's so long.
We bring it down. All right. And then I think we are fine to close it. Okay. Okay, so breathing is on. Then we are excited to see color.
There's a little bit regurg. So we check for the gradient.
All right, it certainly did something. We do see some increase in gradient. Yeah, okay, it's only 1 to 2, but at least the appearance of the flow changed a bit.
You see nicely the tissue bridge, how the leaflets are well in the device. And I think it would be very nice if you can now add the color flow to this view, because we saw it before and now it's significantly better. That's all.
I mean, MR assessment is important because we treat MR. But stability, longevity of the result, therefore I believe it's also important, very important to assess anatomy and the overall appearance of our therapy and intervention. And here, my impression was that we have no distortion. We restored the natural anatomy away from the site of implantation, obviously. So all of these things should be included in your assessment.
So you see that is really traced. So it's 1 millimeter vena contracta and biplane both. So I would say that is really traced to grade 1 maybe.
Okay, let's go to an X-plane. Cursor on the second device, please. I agree, I think we could have more posterior in. Let's have a breath hold, please. Then we open the device slowly and leave the clasp down still. Maybe we don't do anything, but that's another thing which is worth mentioning and helpful sometimes. If you're in doubt, open the device. I will change the appearance and the interpretation of it. And here you can see that we could be better. Let's bring up the posterior leaflet, please. Posterior is up. I go more clockwise. I think we have to come more clockwise. We have to bring up the anterior as well. Otherwise, I can't. Difficult for me to turn. Now it's following, isn't it? Another 3D, please. So I turned to be more 12, 6 o'clock. Okay, good. We bring down posterior again. There you go.
This looks very nice.
Okay, so we have full leaflet in, but no annular tissue. And then we close. Can we pressure tracings on screen, please? Okay, we close.
While we're closing.
Okay, pressures came down again, breathing on. All right, let's do a final assessment. Look at that, and then also at the level of the leaflet, maybe from an LV view, because here sometimes it's overestimated. I mean, please remember we started off with a massive torrential MR with an ERA of 0.9, and now we look at small jets. We have tremendous improvement in pulmonary vein flow. We have a tremendous improvement in left atrial pressures. Mean LA pressure came down by 10 millimeters of mercury. V wave came down 30 millimeters of mercury. Can we have the preview again, please? The initial baseline MR, just to remind ourselves with what we've started off here.
So this is the measurement of 0.9. And here we see that was the vena contracta in biplane. So a huge MR, and that is actually what it is right now.
In conclusion, we had a quite challenging and pretty unusual anatomy, at least something we don't see every day. We had the great advantage of having a surgeon with us explaining of what we are looking at here and what it looks like in situ during surgery.
So without any bias, I think most of us would agree that this is a perfect result with probably an MR 1+, residual MR.
Very nice case and very impressive results. We have some time for comments or questions from the audience. If you have any, don't hesitate. I've noticed that you do all your grasping with a breast hold
Yes,
systematically.
almost always, unless it's really pretty straightforward. But in anything more complex, we like to do breath holds because obviously it gives you more stability, less motion. Normally, during ventilation, the device is moving from medial to lateral, and by have a breathing stop, you get rid of that motion, and the procedure is much easier, and you can be more precise with your steering and with the implantation.
Okay. And we've also seen the optimization. Do you have any tips and tricks for when we want to optimize, when we want to detach and then optimize on another leaflet? What are the checkups you need to do before? Any?
I guess my advice would be that grasp leaflets, but then really take your time and assess everything very, very, very thoroughly. And if you're in doubt, as demonstrated and also discussed, reopen the device because it will help you to understand what you've done and what you potentially could do better. And there's absolutely no risk with that device. If you just open it, you open the pedals, you still have the clasps down, the leaflets will stay in place. There's no risk of losing them, and there's also no harm to the leaflets.
And I think it's an amazing case. And we always discuss that how important is the transeptal puncture. And what about, I think this is a especially particular scenario for that.
Yes. So what we do now more and more often, obviously we aim for transeptal puncture about 4 centimeters, and we try to be posterior. But in more complex anatomies, what we normally add is we double check on a 3D and try to appreciate where we have the tenting and correlate that to the medial commissure. And with that device, you find it much easier and much more straightforward if you really enter the left atrium just above the medial commissure, and also for this case.
Okay, so maybe one last question.
Yeah, there's a question.
Go ahead.
Just wanted to ask you, what is the rate of complications here? I mean, overall complications, let's take 100 patients.
The procedure is extremely safe. The complication rate is very low. When you look at the studies, obviously that includes a certain learning curve. There's some SLDAs, but there's no major complication. I don't think that in the studies there are any conversion to surgery reported, not that I'm aware of. And in general, the extremely safe procedure. Well, it's not so much about the complications, but it's really about obviously achieving an MR reduction as good as possible.
Perhaps usually in these high-risk patients, we're looking then beyond in-hospital outcomes, the 30-day outcomes for severe events, mortality or something like that, it's somewhere in the range of 1 to 2% in very high-risk patients.
It's worth mentioning that with the patient that I presented, this is a patient in cardiogenic shock on inotropes. It's still a safe and predictable procedure and very, very hemodynamically benign. And actually, if you look at the commercial data that you presented a second ago, the risk of mortality or conversion to surgery in the commercial data set during the procedure is 1 in 1,000, which is a very, very low risk that we can tell our patients.
Probably the worst complication is not being able to improve the result. So sometimes the message that you have to give is that the worst thing that can happen that you leave the cath lab with the same result that you got in at the beginning. So
one of the really nice things about these procedures is that procedural complexity does not correlate to patient risk. If you have a difficult TAVI, for example, that's usually high risk for the patient, but a difficult mitral or tricuspid procedure is not high risk for the patient, it's just more difficult for the operator.
Any other questions from the audience?